From my side, welcome everyone to today's webinar. I'm really excited to introduce again three speakers, both from the Netherlands, from Paris and from Switzerland. We are now for the first time with Zoom, and hopefully we will have a really lively exchange. Now, without losing more time, I would like to ask the colleagues from Leiden to start with their first case, please.
So good afternoon, everyone. My name is Kirsten from Langevelde. I am a musculoskeletal radiologist in Leiden University Medical Center, working together with...
Yeah, my name is Demien Broekhuis. I'm an orthopedic surgeon here in Leiden, doing bone tumors. And today we would like to present our case and hopefully have a lively discussion on several aspects during this case, which we treated, I think, for the last 2 years. Yep.
Yeah, so it's about a 19-year-old female. She has a sacral giant cell tumor of bone, so we will already give you that. She presented with no previous medical history and came to visit Demien in the polyclinic.
Yeah, correct. So when she presented for the first time, she was complaining since several months for progressive pain in her left upper leg. I'm just going to see if I can make this a little bit smaller because otherwise we cannot see our own slides. There we go, that's better. In her left upper leg, and she had some perineal paresthesias, yes, and some incontinence of urine. And click, yeah.
Yeah, so an X-ray was done. It's always the best thing to start with if you look at all modalities for bone tumors. And initially the lesion was not seen, and I find that very agreeable because it was located on the left side of the sacrum, and it can be easily missed also due to bowel gas. This was all in October 2019. Luckily, due to the severe symptoms, an additional CT was performed, which you can see over here. And there's a large soft tissue mass extending to the foramen, compressing the sciatic nerve on the left side. And what I further would like to note is that the lesion extends approximately from S3 downward. It's mainly osteolytic and there's no matrix inside. And this was the SPECT accompanying the CT. I'm not quite sure this was performed elsewhere, but there is some uptake in the lesion. It's not massively avid. And I think what we all really want to see in this kind of tumors is the MRI, and I'm showing you it over here. So I'm not sure how many radiologists are attending today. So I'll briefly discuss the sequences. A T1, good for anatomy, shows this lesion with a large soft tissue mass inside the bone, outside the bone, with a lot of these cystic components on a proton density fat saturated sequence. And over here, I drew a small circle around the S3 nerve on the left, which you can see is not super happy in the neuroforamen due to this compression by the tumor. And then again, what's very typical is all these small cystic lesions inside the tumor, and this is called ABC-like changes. And it can be quite common in a giant cell tumor of bone. This sequence is done after contrast, and you can see that there's septal enhancement of the cystic components and also solid enhancement in the tumor itself. And this all fits with a giant cell tumor of bone.
Yeah, so obviously we decided to perform a biopsy to get histopathology diagnosis. So that was done. But during this period, we were waiting for the histopathology results. The patient was urgently admitted to our hospital because her pain was too progressive and too painful. Especially around her left leg. So we had to admit her for especially pain medication. There we go. So during that period, I think it was about 5 days in hospital, the histopathology came back of the CT-guided biopsy, and that indeed showed a giant cell tumor of bone. Unfortunately, we didn't see any signs of malignant transformation in the biopsy. So here we have an important moment in decision-making for this patient, because we have a very young patient with a quite large lesion in her left sacrum. abutting, maybe invading some sacral nerves with a lot of pain, laying in hospital, needing high dose morphine. And obviously we were thinking about what we could and should do for this lady. So I think we should have a short panel discussion about what would be the preferred treatment option for this lady in this case. So we have either a conservative treatment option, so don't do anything. We have surgery, and then we should maybe discuss how. Or we could either do only or combine this with systemic therapy, either neoadjuvant or as a systemic treatment only. So maybe Bruno or other panelists are interested to comment.
Yes, I think that's an interesting case. There are several options. Usually I'm reluctant with surgery. I think, of course, there is a decompression option. That's something we always can consider. I think there is no right or wrong. I think that might be a way to go. Yeah.
Okay, so you would say a conservative treatment over a surgical treatment in this case?
Yes, correct. I mean, of course, you can always consider denosumab, but you know, it always depends on the extent of the clinical symptoms too. Mm-hmm. But I think you know, eradicating the tumor in this location is always very difficult.
Yeah, correct. Are there any other panelists who would have a different opinion or a different option?
I see Shintaro. Are you among us? Can you? What would you do in Japan?
Hi, Bruno, and hi, everybody in Europe. My name is Shintaro Iwata from Tokyo in the midnight. And I have a case of the GCTB, giant tumor bone occurring in the sacrum, S1. And we performed, fortunately, he didn't have the pain on the S1 nerve, but we decided to do the denosumab, and it's very effective to localize the tumor. But unfortunately, he after then he had a pain on the severe nerve pain on the S1 because of the new bone formation on the limb of the tumor. So it affects the S1 root, and then he occur the nerve root pain, unfortunately. So it's a vice versa. It's a little bit difficult to have the new bone formation and do the easy to do the surgery, but sometimes it happens, the pain after such kind of treatment.
And Bruno is also among us. How would you approach this in Brazil?
Hi, everyone. Sorry I was late. So I didn't see the beginning of the case, so I just don't know. Sorry, I'm sorry. Can you repeat, please, like a summary?
That's all fine. Great, you joined us. Well, would you continue?
So yeah, this lady was in hospital having a lot of pain. So we decided to do surgery. So we performed an intralesional resection of her left, and her left-sided sacral roots were decompressed. So S1, 2, or S2, 3. Unfortunately, her left S4 root was too much damaged and had to be sacrificed. And at that time point, we were quite happy with the intralesional resection. We did it aeronavigated, so we can pretty much see where we've been, and we were quite happy that we went everywhere. So we decided not to add neoadjuvant denosumab, as has been suggested by the panel. Indeed, it would be an option. Before we did the operation, I think it's very important to understand that this lesion is a very vascular lesion, but maybe Kirsten can elaborate on this.
Yeah, sure. So I'll be the interventional radiologist of the day. So what my colleague did was put a catheter in the AFS on the right, which you can see here, crossing over to the left side in the AII, so the internal iliac artery on the left. And you can see that there are all these large hypertrophied arterial vessels going to the tumor, providing it, and that this is a big tumor blush seen over here after contrast. And the idea is to actually give particles so that all these small arterioles are occluded. But they found out during this procedure that there were many branches going to the skin, and that can cause massive necrosis. So in the end, they decided not to use the small particles, but to use coils, which you can see over here in two large feeding vessels. So they occluded them, and you can see that the tumor blush nicely decreased, but only on the lateral aspect over here, the vessels remained because there was too much risk that there would be skin necrosis.
Yeah, so post-surgical, she had a good recovery. Her pain subsided actually completely. She could stop our pain medication. Unfortunately, she had to continue with an intermittent catheterization, but she was able to stop that after 3 months. So she could go to the toilet normally. But then, unfortunately, after 5 months, she again presented herself with progressive pain in her left leg. Let me just move this again. In her left leg, and she had some motor dysfunction as well, plantar flexion of her ankle, which was a little bit less than we would like. So we did a new MRI scan.
Yeah, and this is not difficult to appreciate that there's a large residual or recurrent tumor sitting in the same location. It's actually much more hyperintense on T1 in keeping with blood. So all these cystic components have now got some blood in there. This is the diffusion. So diffusion weighted imaging is done to look at solid parts of the tumors and at Brownian motion of water. And here is a very high component on the B1000, and the ADC, which is computed, shows low signal in keeping with solid tumor tissue. And then also what we always do in our bone tumor protocol is we perform perfusion. So that is actually contrast, and you make images every 3 seconds. So it's very fast imaging. And what you then can see is how fast the lesion enhances. And you put a region of interest, an ROI, in a tumor and also in an artery. And this graph is actually quite typical for a giant cell tumor. So this is the artery, and the tumor enhances super fast, almost together with the artery, and then shows some washout. Let me skip this for the time's sake. But what we can appreciate from these time intensity curves are several types of enhancement. So if there is just a hematoma, it shows nothing. If there are other kind of lesions, they can show a gradual increase or a fast increase. And we have a type 4 tumor in our case, showing the washout. And this system works a little bit like benign to malignant, although it's not exclusive, of course. And in the type 4 group, there is washout, and also the lesions shown here are included. So synovial sarcoma or giant cell tumor, or even the nidus of an osteoid osteoma. And this can also help us to see if it's a recurrent lesion or not. So this is very useful in daily practice.
Yeah, so unfortunately we had a large recurrence. Due to the very fast large recurrence, we were worried that this might be a malignant transformation in giant cell tumor. So we did a rebiopsy. And fortunately, it didn't show any malignant transformation. Since her complaints were again pretty severe, we plan to do a re-embolization followed by adjuvant denosumab. To do an embolization, a re-resection, and then followed by adjuvant denosumab, because at that time point we appreciate the benefits of the denosumab in these kinds of lesions, obviously. But unfortunately, the re-embolization failed. There weren't any vessels patent enough to be coiled, and the intervention radiologist told us that the lesion was very, very, very highly intense vascularly. And that's why we decided at the day of surgery that we would not proceed with surgery, but we would start with the denosumab, because we thought that doing surgery with such a highly vascular lesion would cause way too much blood loss, us not being able to do a good decompression of the nerves, and then to have a wider resection as we would have planned. So at that time we started her on denosumab. So here are some image findings of the denosumab start.
Yeah, so I think what's nice to see from these unenhanced CT images is that it's a bone window, so that's done on purpose, and you can appreciate it at baseline T0. You can see that large soft tissue mass is here, the recurrent tumor. It even grew within 1 month since the MR, so it's quite massive. 5 weeks post start of denosumab, there's already some peripheral neocortex formation and also some central density coming. And this is really what you expect. So it goes quite fast. And the best way to see this is not so much on MR, but just actually on plain film for extremities and on CT for axial lesions. And this is 1 year later, and you can now appreciate that it's densely ossified. And this is actually, yeah, it's quite hard and encapsulated tumor by denosumab.
Yeah, so as our Japanese colleague pointed out, on denosumab, this lady got progressive pain of her left S1 and S2. We also thought that it was due to ossification of the lesion in her nerve ramen. It was pretty disabling. So we decided to do a local decompression at that point. And that indeed worked very well. Her pain subsided again, and we continued on denosumab. But then this is a young lady, and she wants 5 children. She actually wants 5 children. So together with the medical oncologist, she decided to take a denosumab holiday to see if she could get pregnant. She did, but unfortunately she had a miscarriage. And at the 6 months of therapy, she again had progressive pain, which she really thought it would be coming from a recurrence. So then we have these images.
Yes, so there was one MR, an interval MR done during denosumab, and you can appreciate that low signal is all sclerosis as seen on CT. And then this is the new MR. You can also see that there's a movement artifact. This is the T1 axial sequence, and there's a new area without this low signal, the star. And also on the CT, so basically she was in such severe pain we couldn't finish the MR, and we performed the CT instead to look at the lesion. And there's now new osteolysis, and new osteolysis in denosumab is often worrisome for malignant transformation, but she was already stopped. So this is what you expect. So this is just reactivation of the tumor after denosumab.
Yeah, after stopping the denosumab.
Yeah.
Yeah, so at this stage, indeed, because she's again in such pain, we decided to do again a navigated surgery, but then do a much wider resection, do a left hemisacrectomy, where we sacrificed the S2 nerve root because it was completely encased in the tumor. And because of the soft tissue compromise, the plastic surgeons did an S-gap flap coverage of the hole that was remaining after the resection. And she recovered very well. Fortunately, this lady recovers actually quite well every time that we operate on her. She needed intermittent catheterization again, but she was actually quite happy. We did a post-op MR after 4 months, I think.
Yeah, and it shows the defect in the sacrum filled with the S-gap flap, so mainly consisting also of fat, and it looks quite nice, and there was no sign of recurrence.
Yeah, so we didn't continue on her on denosumab, so she's off denosumab at the moment. We did quite a large resection, as you can see here, on this 3D reconstruction, but we decided not to do a reconstruction since the soft tissues were quite bad, and we thought that her remaining S1 would be at least large enough for her to be able to gradually start weight bearing. So we took it very slow, and she's gradually started weight bearing. She's doing fine, doesn't have any pain at the moment, but we can see that there's a little bit of subsidence in her left SI, as you can see on the right-hand side here. So there's some movement, but she's clinically doing very well.
Okay, only a few minutes left. So just quickly showing this table, you can also look it up in skeletal radiology for those interested. So what we do expect to see on imaging after denosumab is sclerosis. You can see that on the X-ray or on the CT, obviously. You can measure the Hounsfield units for density during follow-up. Please give no contrast because it's not needed. And even in cases where there is pulmonary metastases, we can also see that there is ossification of the mets on denosumab. So that's a known finding. I'll skip the DEXA. So MR, the low signal matrix, which I showed you on T1, especially decrease of the cystic components, and sometimes the soft tissue mass also decreases in size. And what's quite striking is that if you do an FDG PET-CT, which I would not recommend due to the radiation, but if you have performed it, sometimes they do it, you can see that this tumor responds very quickly, even after 2 weeks, and the FDG uptake decreases. So we come to our take-home messages. So I think from this case, we can appreciate that MR perfusion is useful in giant cell tumor of bone to see, for example, in the diagnosis, if we see the typical washout curve, or also if it's a recurrence versus post-operative changes. If there is a fast recurrence, such as in this lady, think about malignant giant cell tumor of bone. It's something, it's quite rare, but you have to worry about it and rebiopsy to exclude it. And then add a CT without contrast to assess the response. It's very helpful. The rest I will leave to you, Damien.
Yeah, so what's important if you do a resection on a patient who is on denosumab, tell the pathologist that the patient is on denosumab. Otherwise, they would say that there is a caveat for an osteosarcoma because it looks like an osteosarcoma. Also, after intralesional resections, you could consider adding a neoadjuvant denosumab as a local control, especially in the sacral area. And again, as I've been told before, there is room for denosumab as a primary treatment, but we have to consider the side effects. We are known about long-term denosumab usage and the side effects of this. This can cause osteonecrosis of the jaw. It can cause hypophosphatemia, and it can cause limb pain. And it can also cause
atypical femoral fractures,
which we also see in younger patients using denosumab for a longer time. So you have to consider those side effects versus the long-term uses of denosumab. Take this. And as stated here, there are long-term usage possibilities, but the long-term usage on patients who are 19, 20 years of age, and we'll use it for maybe even 20 years. 20 years, we don't know what denosumab does. The longest follow-up on patients treated with denosumab for osteoporosis is about 10 years. And patients treated with denosumab for giant cell tumor of bone, who was unresectable, is about 5 years. And we see that those long-term effects are basically stable, but but we don't know what happens if you take them for a much longer time. I think that is it. Thank you very much.
Well, we have to thank you. I mean, this is really an exciting case. And you highlighted really, on the one hand, the interdisciplinary nature, and on the other hand, you showed, well, an extremely challenging, complicated case. And I think we all can learn just by listening and seeing what you did. I'm wondering, what will be the next? Well, if she recurs again, what is the next option? Have you any thoughts on that?
Yeah, so we will scan her with a shorter interval as we've done earlier. And hopefully if she gets a recurrence, because now she's not on denosumab, and the recurrence is away from nerves and other areas, we can either decide to surgically treated. But we also have options like radiofrequent ablation or cryotherapy, which you can use in lesions which are surgically demanding areas. And our interventional radiologists are pretty happy and keen on trying to control tumors with that as well.
Have you considered that also before surgery to do an interventional ablation?
Before the initial surgery, we didn't because...
No, not initial, the second recurrent before the hemisacrectomy.
It's too big.
Yeah, we didn't know
Too
because
big.
it's too big. Yeah, so it's too big for radiofrequent ablation, and it's even too big for cryoablation. So yeah, and then we couldn't control the nerves as well, so we didn't put it as an option.
Bruno, do you want to mention a word on, let's say, the long-term use of denosumab?
Hi everyone. Yeah, in Brazil we do more or less the same. There is no big difference between these kinds of conduct and the one that we do here. The thing here sometimes is when to operate. Now I think it's a big question for everyone. So the difficulties when you have too much calcification, these kind of discussions we have a lot in here. But yeah, it's more or less the same. But from the point that I saw, the patient was operated twice, no? This one presented.
Yeah, correct. So actually 3 times, but the interval operation was just a decompression of a nerve. So we operated twice. Yeah.
Yes, it's very interesting. Yeah, but yeah, not much to add. It's more or less the same here.
Awesome. And let's say radiation therapy, just because we have quite a few radiation oncologists among us, is a complete no-go. Or any thoughts on that? I assume yes, huh? Well, thank you so much. I think this is really exciting. I think this concludes the first case. Then I think, or I realized that Friedrich is not among us, and the better that we can ask Michiel to present his case. Do you want to go ahead with yours?
Yes, thank you, Bruno. This is a case that we prepared for the former webinar. So thank you for allowing us to present it today. Again, it's a case that we treated a long time ago, a couple of years ago in Leiden. And Kirsten has helped a lot with the slides and the radiology. So thank you, Kirsten, again. It's about soft tissue sarcoma. It's about a tumor of the posterior knee. This patient was 53 years old. He had a swelling of the back of the knee joint. Someone thought it was a Baker cyst. He was treated conservatively and it grew. And then we had these imaging. And since Kirsten is here, she can maybe describe a little bit what you can appreciate, if I'm not putting you on the spot here, Kirsten. Otherwise,
no, it's my daily work, so I'm happy to. So yeah, what we can appreciate is that there's a large soft tissue mass with, this is a T1 again, some cloud-like high signal on T1, and that's also suppressed on the fat set sequence, and this is very typical for lipomatous component in a soft tissue tumor, and the other component that there is seen is very high on T2. I don't want to give it away, but it's definitely not a Baker cyst.
No, it's a bit too much of a mass and too little of a cystic lesion. So patient was, I have to go here, there you can appreciate the nerve going in both sides, so the sciatic nerve and the peroneal nerve, and you can see it from the lateral side, or then appreciated the 22 centimeter lesion, pretty large. Of course, it was biopsied when it was referred, and it was a high-grade myxoid liposarcoma. So I think most of us now would appreciate the effect of radiotherapy in neoadjuvant setting. and the great responses we can see in mixed with liposarcoma. Going back, there were some discussions in other centers where the patient was treated or was seen first, if the nerves could ever be saved. Therefore, why go into radiotherapy? Just take off the leg above the knee joint. So this was proposed. Patient really didn't want to have that. His wife was a GP, so she started Googling and thought maybe radiotherapy was a great choice. So patient was, of course, staged. And the question maybe to the panel would be, before giving it away, is if they would nowadays do standard total body MRIs in mixed with liposarcoma.
Michiel, the question is whether we would use a total body MRI or not.
Yes.
Yes, on our side, we use this more and more. But on the other hand, the radiologists are not too happy because I think the clinicians have a more lower threshold to use it, and that adds up in their capacity, of course. So that's a continuing issue on our side, at least.
Okay, and how in Japan, Shintaro?
Yeah, thank you, Michiel. So we usually did not to do the whole body MRI because of the not covered by insurance. But of course, the spine is a very important part of the region for mixed lipo. So that's why we combined, we performed the CT, whole body CT, and spinal MRI. That's the routine scan for the mixed lipo.
Yeah, so in our center is generally not done in a standard manner because of what Bruno has said. There's not enough MRI space because of the fact there's not enough evidence that supports the use of so much extra MRI space. So we still do abdominal CT, chest CT, not per se total body CT, but this could also be a great option, I think, Shintaro. So, of course, in this case, the CT of the chest didn't show any metastasis, but we did do a whole body MRI. I have no idea why I did that, maybe to prove to the radiologist that that was a good idea. And of course, then we found this lesion, which is highly suspicious of a metastasis of his mixed liposarcoma. And it was biopsied, and it was proven to be one. There you go. It's everywhere visible on any slide. So it was biopsied, and it confirmed metastasis. So now we have a metastasized, very large mixed liposarcoma of the posterior side of the knee. Anyone wants to maybe discuss treatment possibilities as either being above knee amputation or just radiotherapy and see how it goes? Do we need to resect the metastasis or just radiate it? Many options to be discussed. I'm very interested in what others think.
Well, really intriguing. I think for the primary lesion and knowing that these type of sarcomas can respond very well to radiation, I would really go for radiation. And of course, still having an option if really necessary to amputate, but I would be reluctant to amputate given the metastatic nature. So I would hope pre-op radiation and then see what the decrease of the potential decrease of the size of the tumor will be, and treat this basically separately. And for the iliac intraosseous lesion, probably maybe also radiation or ablation. But of course, I'm interested what the radiation oncologists will think on this aspect.
Yeah, I certainly would go for radiation first to large mass in the leg, and I would go for probably ablative radiation of these metastases.
Okay, I think that's a great idea, but I'll show you later why. And in Japan, how is that? Are you doing anything different?
Yeah, it's for me it's a little bit tricky. Even if we perform the neoadjuvant radiotherapy for primary lesion, it's a little bit reluctant to save the limb because the nerve it goes through the inside the tumor. So yeah, it might be one option to preserve the limb, but I had to decide, but one option was the amputation finally.
Okay, when
even in a bone metastasis, yeah, I know that.
Okay, and what would you do with the bone metastasis?
Oh yeah. It's difficult. Yeah, it's also it's acceptable for do the radiotherapy only for the bone metastasis, but
okay, so we have different options around the world. We did radiotherapy neoadjuvantly, and we did see some decrease in the tumor size. So there was a response.
Michiel, given the fact that Andrew Bishop is also among us, among the participants, and given that he published just recently in Lancet Oncology in December about hypofractionated radiation therapy, may I ask you what type of radiation pre-op you did use?
Yeah, that's a good question. So the Do-Re-Mi study that was performed in several units around proved that there was not a superior effect of 50 grays over 36 grays. So we started to do 36 grays on most of the myxoid liposarcomas in our unit. I believe also this case only had 36 grays.
Awesome.
Maybe it would have shrunken a little bit more, either by time or more radiotherapy. I don't know. The nerves were not free. So Shintaro, you are right. It's very difficult. And then I remembered the presentation by Jay Wunder saying that you can try and resect the tumor and then dissect the nerve out of the tumor while the tumor is still almost connected to the patient, by putting a sheet of plastic in between the tumor and the patient. So that's what we did. We took out the tumor and we saved both nerves, and they were functional, so that was good. And then we did cyberknife radiotherapy on the lesion in the iliac wing. So teaching points: whole body staging, either with MRI or CT, may help in finding lesions that we would have not found, and maybe they will infect the treatment decisions we make. I think that's something we should consider. It's great that the panel already acknowledges that cyberknife treatment of bone metastasis in myxoid liposarcoma is a good option. R1 resections with radiotherapy, as was done, shown by Jonathan Pereira and in a multi-center study, is just as good together with radiotherapy as an R0 resection in myxoid liposarcomas when we look at local control and overall survival. So that's why we saved the nerve, and in the end, of course, the disease caught up with us. So 3 years down the line, we decided new bone metastases that are currently treated in Australia, where it now lives. So thank you very much for your attention.
Thank you so much. Really exciting. I think it shows the wide variation of approaches we have, and there's no one single best. I think this is really exciting. I don't want to put anyone on the spot, but if Andrew wants to join and give you a comment, please feel free. That would be awesome. And of course, I'm also interested what people in Brazil would handle this type of tumor. Please, Andrew, I see you.
I don't know if Guilherme is here. I can't see him, but I would like to ask about the chemotherapy because it's a metastatic tumor and it's a sensitive tumor to chemotherapy. Would you go for chemotherapy, maybe chemo radiation, like combine it?
Very good
also
point.
Also, trabectedin in liposarcoma, in mixed liposarcoma is a good response when in combination with the radiotherapy. So would you consider also that, and also after maybe to treat the bone lesions with direct radiotherapy, maybe combine everything?
I think that's a very good option, and I think chemotherapy in the Netherlands is still a little bit in a conservative part of the treatment. So the oncologists are not always very happy to give chemotherapy to primary soft tissue sarcoma. But I agree, in specific types where we have now more targeted therapies like trabectedin, I think this is something 3 years ago we didn't know yet, or maybe not knew enough, and may consider to do and use now.
I think some months ago, Javier Martin Voto presented a case here where preoperative radiation was combined with trabectedin, and it showed a great response, and they published these. I think that's really a very good option also to consider in case. But as you report, you have control over the tumor, and so whenever it should recur, this is still an option to consider. Any other questions? Thank you so much. I mean, great cases from Leiden. I really appreciate. Thanks for your efforts. I know it's always a huge thing to present this, but I'm convinced we all can learn just by seeing these cases. Let's go over to the third case. We have in the last webinar seen a case from Brazil, where we had this lattice grid technique introduced, and the advantage of this format that we have here with the webinar, we can connect people, and with the exchange between Gabi and Bruno and the team, there's now an exchange, and Gabi chose now to give a little bit more background on this, maybe for many people not so well known type of radiation. Gabi, please.
Yeah, thanks a lot. So today I'm supposed to speak about lattice radiation. So it's my great pleasure to start with a case presentation, followed by some background information on lattice technique, and finally to share with you some first experiences on lattice from our center. So I want to present you the case of an 88-year-old female with severe dementia and large G3 UPS of the knee, no metastasis. This is the clinical presentation before treatment. You see on the left this big mass. You see the MRs. It's a proven UPS G3, for months misinterpreted as hematoma. So this mass measured 17 centimeters, 880 cc. Here you see burst skin already, so close for exulceration. You see the distal edema, you see the biopsy defect. Question, how would you want to proceed? Best supportive care, surgery, palliative systemic treatment, palliative radiation, or even some combination.
So Damien, maybe I can ask you to give your impression.
Myself?
Or Shintaro. What do you think?
Yes, I believe that I'm a surgeon, so that's why I will select the surgery for this patient. But maybe the combination with the palliative radiotherapy.
So maybe I give the answer myself. So Bruno Fuchs told us when we go for surgery, this patient will not walk anymore because she's old and she will not be able to learn to recompensate and to walk again. So, and this patient has dementia, severe style dementia. So we said, okay, let's try and let's go for radiation. So next problem, what schedule do we choose? Question about 10 to 15 times 3, something like that, or maybe 60 in 2 gray, totally different schedule. What do you think?
Andrew Bishop told me before that he has problems with the microphone. I see you are activated. Maybe you want to join?
Yes, can you hear me?
Awesome, great.
Apologies, I was having technical issues. Yeah, so I think that's a really interesting question. Typically, in a scenario like this, what we're doing at MD Anderson is we are offering kind of a more aggressive palliative radiation therapy approach using hypofractionation. So I generally would lean towards option number 1 here, going to 3 gray, 3.5 gray per fraction. Oftentimes, we're taking these tumors around 45 to 52.5 gray, with some sort of integrated boost in order to try to escalate the dose and provide some both palliative benefit as well as durable tumor control.
Thank you. So we decided to go for hypofractionation, ultra hypofractionation radiation with a simultaneous integrated boost using the lattice technique, meaning 5 times 9 gray to this hotspot spheres, 5 times 7 to the mass, and 5 times 4.5 to some margin around the tumor. This is basically prescribed by Drusetti in 22:1. And we had to put a huge flare, 20 times 20 centimeters, because of the entire skin, as you saw before, was affected. So we did 5 fractions and we measured with a CT. Pre-treatment was 880, post-treatment day 0 after 5 times radiation, shrinkage of about 15%. Hard to see here, just measured. That's the same on a lateral view. The early clinical reaction, you already know this peak here, pre-treatment with this close to exfoliation skin, 0 days post-radiation, less tension, 18-day post as expected, 28 days after grade 3 to 4 dermatitis of the fully exposed skin as expected, day 50, well healing. The same from the lateral view. Then day 70, we got a photo from family. Me already kind of okay, but here new swelling, here new swelling. New photo 90 days post-radiation, bad swelling of the leg. So we decided, despite of the age of this patient, to go for a restaging CT scan. So this was 4 months post-radiation. So we found multiple lung mets and we found this in her groin, ipsilateral groin, so metastasis. We went for urgent ultra hypofractionated radiation with 6 times 6 grade to the mass, 6 times 4 to surrounding tissue, here in blue. 2 weeks later, slim lower leg again, look at that. 20 days post, slim lower leg again. Here we have, in the upper leg, we have still this edema. basically, this patient was rollator mobile as before, low pain level, but progressive metastasis. The lady died 5 months post-lattice, however, with preserved function, with pain in control, and with no exacerbation. I come into the second part of my talk, some background on lattice. So actually, we experienced a paradigm change in radiation oncology. So before or till now, we put lots of energy and time into homogeneous dose distribution. So that was very important for us to get homogeneous dose distribution. Now, from homogeneous dose distribution to inhomogeneous spatially fractionated RT, so-called SFRT. So the principle of higher normal tissue tolerance using SFRT is known at least since Albin Köhler. I'm going to show you this crazy story. So Albin Köhler was a German doctor publishing back in 1909 that he put 1 millimeter iron grit wire fastened with adhesive tape on skin and gave kV X-ray Röntgen dose. So that was the era, that was the only radiation you could give, Röntgen X-ray. So that's the skin with this kind of grid. You put dose on it, and what happens, the usual thing is you get reddish skin in the exposed areas, then red skin. Depending on the dose, you can get necrotic islands. And Dr. Köhler observed peripheral regeneration of necrotic islands from grid-protected skin. So he observed much faster healing after such treatments than without grid. He observed 3 times higher kV RT tolerance, meaning you can put about 200 gray instead of 60 to 70 gray, which is crazy. I mean, 40 years later, some other colleague took the issue again, clinical experience with radiation through a grid. Then there happened further development in the megavolt era. This is the linear accelerated era for mainly bulky advanced tumors. So Mohioddin and his team did a lot of writing work and experience description on that back in 2009 and following years. So meanwhile, you have quite a lot of papers on these 2D grid techniques. So I'm showing you the difference between homogeneous radiation and inhomogeneous radiation. This is homogeneous. You're getting below this homogeneous dose distribution. When you go for inhomogeneous treatment in the MD era, you can collimate your beam, you can change your beam, for example, with lamellar collimation, and you're getting these peaks and valleys in your dose distribution in the tissue. And as you can see, you can go higher to get the same effect or the self-tolerance as when you go for homogeneous treatment. There's another option in the grid era to put this technique. You can use borehole collimators. And this group around Sande, they performed a phone survey in 5 RT centers in the US that have used grid therapy, and they found that at least 2,000 patients have been treated with this borehole technique back in 2020. So, grid SFRT concept inception more than 100 years ago, then resurgence of SFRT in the MD era with linear accelerator, and the next step, finally, lattice RT. Introduced in 2010, it's a kind of 3D version developed from the 2D grid, and it translates into improved therapeutic ratio in bulky tumors. So in this paper, there's some nice illustration of the difference between 2D grid radiation with borehole technique and lattice. Lattice is 3D, and you can create these hot spheric areas, and you give some lower dose to the entire mass. So safety and clinical efficacy of lattice has been reported in various voluminous tumors in quite a bunch of papers. Meanwhile, I'm showing again the concept. This is the entire tumor covered with kind of low dose, and you put some hotspots islands, some spheric islands, and you're getting this peak valley dose distribution. So that's the key principle. Put peak doses surrounded by low dose valleys to get the potential to offer significant improvement in the therapeutic ratio. Mechanisms still unclear, but involve vascular effects, bystander effects, abscopal effects, stem cell and immune response. So quite complicated story. Principle, as mentioned before, high dose peaks inside tumor, of course, surrounded by low dose valleys. So you can find, meanwhile, some few phase 1 trials, all on palliative indications, all phase 1. You see 2020, 21, so it's brand new. And you see still little small sample sizes of patients, and just still one from press. Lattice radiation therapy in clinical practice, a systematic review from this year from Italy. These colleagues found 7 case reports, 1 case series, 4 clinical studies, in some about 80 patients, and they found confirmed safety of lattice treatment, and they found a median shrinkage of about 50% or more. These are the cases they collected. So far, 14 soft sarcoma tissue patients among the collection. Started in 2015 and mainly 22. So maybe to summarize, we have several SFRT techniques in clinical use. We have some preclinical use, a mini microbeam flash treatment. So the characteristics are crit in the KD era from Alban kernel, you know, iron crit, then the crit in the MV era, lamellar or borehole concept crit. You can also perform with proton beams. So they have scan techniques, lattice 3D using hot spheres, mini microbeam, difference of those zones. They use microscopic dimensions, and flash, very exciting thing, very high dose rates, more than 40 gray per second. I'm coming to the last part. So lattice at our institution, we use it for large tumors since 1 year. What is meant by large? Things like that. So these are heavily pre-treated patients. So kind of radiation oncology joins the game rather at the end of the food chain, let's say. So at that point of palliative situation, we have to remember, do not hurt, and we need to know when to say no. Maybe 1, 2, 3, 4 years earlier, we would have said no to most of the situations, to be honest. With lattice, we have some new options. I'm going to show you our cohort. We treated so far 23 patients on 29 lesions, 8 patients aged 18 to 88, 11 sarcoma lesions, mean tumor diameter about 15 centimeters, mean tumor volume 700 plus cc, previous RT in some patients. The follow-up, according to this palliative cohort, of course, some few months. Early reactions nearly 0, but when we include the skin. Late effect so far none. Therapeutic effect objective shrinkage about 50%. Sorry. Subjective benefit substantial fast improvement of symptoms in nearly all patients. It's really amazing. I'm going to show you our so far star patient. I love this case. This is a patient with a bad intestinal carcinoma disease, several treatments before, came with this mass. We did a 5x4 gray, 5x13 gray lattice to a nearly 400 cc mass. 5 months later, 25 cc residuum. Patient is very happy, of course. So lattice has a potential to offer significant improvement of the therapeutic ratio versus homogeneous RT. Well tolerated, high patient's comfort, more effective than homogeneous RT. This is short-time data, of course. As mentioned, the mechanisms are still unclear, the optimal techniques, schedules unknown, so far only phase 1 trials available or active. Combination with, for example, immunotherapy, not yet available. Indication spectrum, mainly palliative so far for large masses. First curative intent analysis, however, are available. This may come up. Outlook regarding radiation lattice system at our center. We plan a prospective randomized phase 2 trial, and we are very happy to already got some collaboration with other centers, with Dr. Sedelmeier and Bruno. Thanks a lot.
Well, we have to thank you, Gabi. I'm impressed. That's really awesome, and that gives us a great overview of this opportunity and what's really behind. I think first I would like to ask Bruno to complement and add to, let's say, this aspect of radiation.
Yeah, first of all, I'm sorry because Guilherme is not able to connect right now. He had a problem at the hospital, so he'll be the perfect person to discuss this. But yeah, here in Brazil, me myself, I just knew Lattice 2 years ago when I came back from Italy with Guilherme, and they used to do a lot to these patients, heavily pretreated, as Gabi just said. And you have such a good experience. So these patients with big masses after 4th, 5th line of chemotherapy and nothing else to do systemically. And that is kind of a mirror sometimes. So we are trying to create this database to collect the cases, collect the information, and to write these phase 2 collectively with your group. So it will be such a great pleasure to collaborate to this kind of information and maybe to bring this technique to the first line setting, because we have such impressive, of course, Gabi might say better than me, but sometimes the toxicity is not that easy. If you have not these big masses, but when you have such a huge mass, the toxicity is not that easy. But yeah, after all, the patient usually goes very, very well, and for a long period. So like months. Imagine a patient almost die and then become like a POG1. So it's super nice to see after many, many lines of treatment.
We actually
Thank you so much.
Sarcoma cases together. Yeah.
Andrew, I would, of course, be desperately interested what you think about what your opinion is and how you contrast what you heard right now.
Yeah, sure. First, I want to thank Gabriela for a great presentation. I thought that was really interesting. I myself and, my colleagues, we don't have a lot of experience with spatially fractionated radiation therapy. We have not employed this lattice technique, but more data are emerging, and I think the results are really interesting and promising. So, we certainly look forward to, you all taking the lead at publishing some of these data and really getting that message out there. I think that there's a lot of utility for this type of treatment. Many of the, as Gabriela pointed out, many of these tumors are very large. They're abutting critical structures, and getting dose high enough to provide tumor control in when they're abutting those structures can be quite difficult. And so we find ourselves often underdosing certain parts of the tumor intentionally to keep the nearby structures safe. But this spatially fractionated radiation technique really, allows for that approach, escalating the dose to various parts of the tumor and really minimizing the toxicity to other areas. One question I have for Gabriela is when you design these radiation plans, how do you choose certain areas within the tumor to dose escalate, or what's the approach to that?
Yeah, basically we don't know. So we make sure we go not too close to critical organs with these hot spots, of course. Second, you should put them with a certain distance, probably about 3 centimeters, to be able to create these cold valleys in between. And otherwise, regarding, for example, should we avoid necrotic zones to put spheres in? We just don't know. No idea.
Okay. And do you design the size of that hotspot based on the size of the tumor, or is the hotspot kind of uniformly designed for regardless of the type of tumor and the size of the tumor?
We just at the moment follow the principle of Turiseti et al., and they described about 1 centimeter diameter spheres, hot spheres, and about 1.5 to 2 centimeter cold valleys in between. So we put the 3D mechanism in our planning system and just put 1 centimeter balls.
I see. Yeah, really interesting. And thank you for that presentation.
Thank you. But basically, we have to be very honest. I mean, we don't know. Maybe we need more distance in between the spheres. Maybe we, no idea. We just try to follow one principle to get some experience you can compare.
Yeah, so Shintaro, I know that it's already past 2 o'clock in the morning in Tokyo. If you're still among us, maybe you want to share the experience that in your center, how you approach, let's say, these huge tumors, and whether, let's say, if you do not use lattice, how do you approach these situations?
Yeah, thank you very much for your great presentation, Gabi. And I heard this technique in the last time maybe in this meeting, and it's so surprising for me for the effectiveness of the huge tumor. Unfortunately, I never heard about this kind of technique inside Japan in any kind of conference. But so in this situation, we performed IMRT or MRI guided concentrated radiotherapy meridian, called meridian, or sometimes we send to the patient for the proton or carbon ion in Japan. Fortunately, in this in my country, so But I would like to tell my colleague in radiotherapist in my hospital about the lattice technique. Yeah, thank you very much for sharing the information.
Gabi, from your side, any concluding comments?
I think it's really fun for us to have got this connection with Bruno and Monique and William, and we try to put data together, and yeah.
Well, this is awesome. I'm really excited about what we learned a little bit more than during the last hour. I think it's great what you present us all prepared to share with us. It's a great contribution. And I cannot thank you enough. Personally, I'm already looking forward to our next webinars. And I would like to hand over.